This is a mechanism of disease map for type 3 hypersensitivity. I'll be talking about the etiology, the pathophysiology, and the manifestations of type 3 hypersensitivity reactions, and that means I'll be talking about many examples of diseases that follow this pathophysiology. As in all of these flowcharts, each of these boxes is color-coded according to the core concepts listed in this legend up here. And I'll be clearing each of these boxes and going through them, talking about them one by one. Let's get started with etiology. Type 3 hypersensitivity begins when you have an IgG in circulation, so an antibody. It doesn't have to be IgG, but it usually is. We'll have one example where it's IgA, but in the vast majority of cases it's IgG. And you also have a soluble antigen in circulation. Now this antibody and this antigen are going to form an immune complex. In fact, it's sometimes called an antibody-antigen complex. So this is kind of what makes this type 3 hypersensitivity different from type 2 hypersensitivity. In type 3, in this case, the antigen is soluble and it's kind of flowing around your body in your bloodstream. In type 2 hypersensitivity, which you might remember as cytotoxic reactions, this antigen was actually attached to a cell or a subset of cells. So you'll actually be attacking those cells or attacking a certain tissue. In this case, the antigen is not attached to a cell, it's flowing around. The immune system still finds it, you'll still have these complexes that form, but these complexes then deposit in tissues. So type 3 hypersensitivity is more about antibody-antigen complexes depositing in tissues, as opposed to the immune system specifically attacking an antigen on a target cell. Now, where do these antigens come from? They can come from all over the place, really. So the color coding here kind of comes in handy. So they can come from the environment. They can be toxins from the environment. They can come from our diet. They can be something that we ate. They can come from drugs that we've taken. A lot of times these manifestations are iatrogenic. They're from a medicine that someone took or an antibiotic, for instance. They can have infectious etiologies. A lot of these type 3 hypersensitivity diseases are sometimes triggered or they flare after a viral infection. And in some cases, you can have cell damage, like tissue damage in your body that produces its own type 3 hypersensitivity with molecular mimicry. But in any case, the point here is that you'll have an immune complex that's still in circulation, and then that immune complex will be deposited in tissues. So instead of attacking your tissues directly, you're attacking these antigens in circulation and then depositing them in tissues. So I wanted to make that difference clear. You can deposit in all sorts of places throughout the body. It can be in your blood vessels, which would cause a vasculitis. It could be in your joints, such as in rheumatoid arthritis. It can be in the glomerular basement membrane, such as in some of the renal diseases we'll see when we get to the manifestations here. Once those immune complexes deposit in these tissues, it initiates the complement cascade. That, of course, is going to cause some inflammation, and it'll actually attract even more inflammatory cells like neutrophils. So the neutrophils will have chemotaxis, they'll approach the deposited immune complexes. When the neutrophils arrive, the antibody, the IgG, will bind to the Fc receptor on the neutrophils, and that causes the neutrophils to release lysosomal enzymes. These lysosomal enzymes are very caustic. They're going to damage the local tissue, which can lead to cell death and cause even more inflammation. So you'll kind of have this cycle of inflammation, and you'll have increasing inflammation through multiple means, starting with this complement cascade. This is essentially the pathophysiology for all the diseases we'll talk about. The major differences are where the complexes were deposited and how the diseases manifest, and of course the severity of the diseases. There's also some variability in where the antigens came from, but it all comes down to this immune complex, antibody-antigen complex being deposited in tissues. Now let's go through the many diseases that we wanted to mention. The first one on the list is systemic lupus erythematosus. This disease is characterized by on and off symptoms, remission and relapsing symptoms affecting almost any organ system in the body. I think every organ system really, except for the GI tract. The GI tract might be least affected in lupus. Common symptoms include arthritis, malar rash, which is a butterfly-shaped rash on the face, Raynaud phenomenon. This is a vasoconstrictive problem in the blood vessels going to your fingers. Your fingers can become rigid and frigid, so cold, and they can change color. You can also have fever, fatigue, pleuritis, and pericarditis. So the patient might present with pleuritic, sharp chest pain and a friction rub. And you can have neurosymptoms as well, which might manifest as seizures and psychoses. Lupus is also a very procoagulant state. So you could have thromboses, and it can affect your kidneys specifically, and that would be called lupus nephritis. Next disease on the list is type 3 hypersensitivity causing rheumatoid arthritis. Rheumatoid arthritis is characterized by joint pain and swelling, synovial destruction, deformities, and morning stiffness in the joints. The joints most commonly affected are the MCP and PIP joints. This is metacarpal pharyngeal joint and proximal interphalangeal joints. So it's kind of the joints at the very tips of your fingers. The rheumatoid nodules can appear as well, and that'll be like a mark on your skin. In addition to these symptoms, you can also have pulmonary fibrosis, atlantoaxial subluxation, and Felty syndrome. That's part of rheumatoid arthritis. Pulmonary fibrosis would present as dyspnea, shortness of breath, a dry cough, fatigue, and inspiratory crackles. Atlantoaxial subluxation is a problem with your cervical spine. The patient will present with neck pain, cervical radiculopathy, and possibly spinal cord compression. And Felty syndrome is a triad consisting of arthritis, joint pain, splenomegaly, and neutropenia. So that's rheumatoid arthritis. Next one on the list is post-streptococcal glomerulonephritis. This one is triggered by a group A strep infection. So this could be a throat infection, it can be tonsillopharyngitis, but it can also come from a skin infection like an impetigo caused by group A strep. The patient, in this case, in post-streptococcal glomerulonephritis, will have a nephritic syndrome. So they'll have hematuria, that's blood in the urine, so the urine might be tea or Coca-Cola colored. Patient might also have mild proteinuria, which you would notice on a urinalysis, as well as edema and hypertension. Another kidney disorder, this one tends to be a little bit milder, is IgA nephropathy. This is the exception to this IgG in circulation that I mentioned earlier. This one is IgA immune complexes. And it usually is triggered by a mucosal infection, either a respiratory infection or a GI bug. And it causes these IgA immune complexes that deposit in the kidney. So some of these are actually asymptomatic, and the patient might not have any symptoms at all. In more severe cases, the patient will have recurring episodes of gross hematuria, flank pain, low fever, and possibly nephritic syndrome, so mild proteinuria, edema, and hypertension, as we mentioned above. But these are the two kidney disorders that would be relevant to type 3 hypersensitivity. Next, we'll mention a few vasculitides. The first one is polyarteritis nodosa. This is a vasculitis of medium-sized vessels. Patient will present with fever, weight loss, muscle pain, joint pain. They can have an AKI, which might present as hypertension. They can have a heart attack, a myocardial infarction, which might present as chest pain and sweating. Polyarteritis nodosa can affect the skin, so the patient can have rash, ulcers, nodules. They can have neurosymptoms, including stroke and polyneuropathy affecting the limbs. GI disorders also happen. They can have nausea, vomiting, diarrhea, actually blood in the stool, and of course abdominal pain. This polyarteritis nodosa affects many organ systems, but it characteristically spares the lung, and that's actually how you might differentiate it from other vasculitides on your differential diagnosis for a patient with many of these symptoms. The other vasculitis that's worth mentioning for type 3 hypersensitivity is cutaneous small vessel vasculitis. This one's also called drug-induced vasculitis or hypersensitivity vasculitis. It can be triggered by a viral infection, most commonly HIV and hepatitis C virus, and there are some drugs that are known to cause it as well, like propylthiouracil, hydralazine, and allopurinol, which is a gout drug. The symptoms in cutaneous small vessel vasculitis include tender, symmetrical, palpable purpura on the lower limbs. You could have subcutaneous nodules in some cases, as well as urticaria, ulcers, vesicles, and some patients have joint pain or arthralgias in this disorder as well. Next is Arthritis reaction. This is a disorder that's triggered by tetanus or the diphtheria vaccine, which actually creates the antigen for the Arthritis reaction, and it's actually quite similar to cutaneous small vessel vasculitis. They have similar symptoms, so they'll have swelling, erythema, hemorrhage. They might even have a superficial skin necrosis after the booster vaccine for Tdap, for tetanus and diphtheria. But it's essentially a type 3 hypersensitivity reaction that's occurring after somebody gets a tetanus or diphtheria vaccine. Presents similar to cutaneous small vessel vasculitis. Next is hypersensitivity pneumonitis. This one has several potential antigen sources. There is some genetic predisposition to it. It's not very well understood, but we do know that it can have some genetic predisposition, and it typically happens in farmers for some of the reasons that'll be kind of obvious once we look at these environmental toxins that can cause hypersensitivity pneumonitis. So you can get it from bird droppings, you can get it from spores, fungal spores. This can be from air conditioning, HVAC systems. There could be spores in hay, there could be spores in sugarcane and cheese casings. There are even spores that live in paints and like compost. So farmers might interact with those substances, those toxins, more frequently. There are microbes found in sawdust that cause hypersensitivity pneumonitis. And lastly, there are some chemicals like isocyanates that can trigger this disorder as well. The presentation of hypersensitivity pneumonitis depends on the course of the illness. In acute cases, you'll have fever, flu-like headache, body aches, malaise, and fine crackles on your lung exam. In the subacute case, you'll have insidious cough, dyspnea, fatigue over weeks to months. And in the chronic case, probably the most severe case, you'll have progressive shortness of breath, weight loss, cough, fatigue, cyanosis, and rales. It's also common for hypersensitivity pneumonitis to kind of have a presentation that's on and off, depending on whether the farmer or the patient is working with these substances. So perhaps they'll have kind of allergy or asthma-like symptoms every time they work with the moldy hay or every time they clear the bird cage and interact with the bird droppings. So it doesn't necessarily need to be an on or off thing. It could kind of be intermittent symptoms for hypersensitivity pneumonitis. The last one on this list is serum sickness, and there are also a subset called serum sickness-like reactions. This can be triggered by several medications, including antitoxins and antivenoms, as well as allopurinol and antibiotics. Some viruses like hepatitis B and rabies have also been shown to cause serum sickness. The patient in this case will present with fever, rash, arthralgias. This usually occurs 1 to 3 weeks after exposure to the antivenom or the antitoxin. Patient might also have lymphadenopathy, plus minus headache, plus minus blurred vision as well, plus minus abdominal symptoms like pain, nausea, vomiting, diarrhea, and plus minus edema as well. So kind of in general, look at all these manifestations. You can kind of get a sense for where these complexes deposit, and I've listed them here. The blood vessels leading to the vasculitis-like symptoms, the joints leading to arthralgias, the glomerular basement membrane leading to the nephritic syndromes that we've seen in IgA nephropathy and post-strep glomerulonephritis. And then, of course, there's those constitutional symptoms that you get with any inflammatory reaction like fever and just general malaise. This has been a short video on type 3 hypersensitivity. I hope it was helpful. In short, you can remember type 3 hypersensitivity as the immune complex deposition disease, and that might help you differentiate it from type 2 hypersensitivity, which is a cytotoxic reaction. And going back even further, type 1 hypersensitivity is an allergic reaction that usually happens systemically and pretty quickly, pretty rapidly. I hope this review was helpful, and thank you for listening.